You told them exactly what was happening to your body. They wrote something down. Then they said it was probably stress or anxiety. Maybe everything looked normal. You left with nothing. Not a diagnosis, not a treatment, just a form. Not because nothing was wrong, because someone decided that before they finished looking. There's a behavioral sequence documented across clinical literature running on 3 moves: deny, attack, reverse victim, and offender. Dr. Jennifer Freyd documented it in 1997. University of Oregon. On record, that sequence runs in personal relationships. It runs inside medical institutions too. Same architecture, different building. If you've left a doctor's appointment more confused about your own body than when you went in, that recognition is data, not paranoia. When a physician minimizes what you report without clinical basis, that's been formally documented. Attributing physical symptoms to stress. Discharging a patient whose pain can't be measured. That's not a communication breakdown. The pattern has a name: medical gaslighting. Not a patient advocacy term, a formally recognized clinical phenomenon. A PA classified, published in peer-reviewed medical journals, on record. The mainstream explanation for this is medical complexity, overburdened systems, communication gaps, honest mistakes by well-meaning physicians. The AMA released a formal acknowledgement in 2023, systemic dismissal bias. Not individual clinical error, a documented institutional pattern. That distinction isn't semantic. One demands systemic change. The other only demands an apology. The AMA chose the word systemic. That choice is on record. 3 structural conditions are present in every appointment. The mechanism exploits all of them. The authority gap between physician and patient. Decades of social conditioning toward medical deference built before you ever needed a doctor. And the genuine vulnerability of someone in that room, asking for help. Those 3 conditions together make credibility attacks present as standard differential diagnosis. Your resulting self-doubt feels like appropriate humility. It was manufactured. If you've made it this far, you've been in that room, or you've watched someone walk out of it with less certainty than they walked in with. The dismissal doesn't distribute randomly across patient populations. Women, Black patients, and chronic pain patients are dismissed at measurably higher rates. Same symptoms, different patient, different outcome. The CDC Office on Women's Health documented this across patient populations. Published data. Drop 1 word in the comments. Just 1. You already know which appointment this is about. Because this is where the pattern connects to something documented outside medical training entirely. The dopamine and cortisol disruption documented in cyclical abusive relationships has a parallel mechanism here. A patient who gets dismissed once returns for validation, gets dismissed again, returns again. The brain doesn't disengage from unpredictable credibility cycles. It locks in deeper, searching for the appointment that finally confirms what they already know about their own body. That search doesn't feel like confusion. It feels like persistence. Intermittent validation of patient-reported symptoms runs on the same variable ratio reinforcement schedule, the same neurological lock-in, the same fMRI data. Different context. Variable ratio reinforcement. The brain stays. The brain searches. A patient's continued pursuit of medical validation isn't a character trait. It's a documented neurological response to unpredictable credibility outcomes. The structural layer is where this stops being a collection of individual bad appointments. Medical training encodes credibility hierarchies before any individual physician makes a clinical decision. Certain symptom presentations get assigned higher credibility. Others get assigned lower. That assignment happens in training. Before the appointment. Before the patient enters the room. A patient presenting with unexplained chronic pain hits a credibility floor built before they arrived. The physician didn't build that floor. They were trained on it. That's not a defense. It's the structural finding, and it's more disturbing than deliberate intent. Research documented in peer-reviewed emergency medicine journals tracked the wait-time differential. Women waited measurably longer than men for equivalent pain complaint treatment in emergency rooms. That gap narrowed when the attending physician didn't have the patient's gender information. The bias wasn't in the system's response to pain. It was in the system's assessment of who was reporting it. Same pain. Different patient. Documented. The framing that protects this pattern is clinical judgment, physician discretion, individual expertise, case-by-case assessment. Clinical judgment is the structural mechanism that converts institutional bias into individual decision-making. It makes a systemic pattern disappear into a personal choice. A pattern that can't be named as systemic can't be addressed as systemic. The systemic layer is where the harm compounds beyond the appointment. A patient who was dismissed once learns to present differently next time. They minimize their pain rating before the physician asks, apologizing for wasting time before the exam even begins, bringing written documentation just to prove they deserve to be heard. That adaptation is documented. It's also what the system then reads as lower severity. The patient's learned response to previous dismissal becomes the evidence used in the next dismissal. That's a closed loop. Architectural, not accidental. This whole script, every study, every pattern, described a building you've been inside, not a broken system, a system functioning as designed. Your doubt was the outcome, not a side effect, the mechanism. This doesn't only describe one appointment. It describes any system built to hold you inside your own uncertainty. If this just explained something you couldn't name after that appointment, you know what to do. The exit from this pattern isn't finding a better doctor. It's knowing what the appointment was built to produce before you walked in. No contact is a clinical recommendation for neurological recovery from a trauma bond. The medical equivalent isn't refusing care. It's refusing to carry their version of your body home with you. They moved your baseline in that room, not your understanding of your condition, your trust in your own account of it. You don't need their validation to know what happened to you. If nobody in your medical history ever warned you this was a documented pattern, this channel is the warning. Make sure the next one reaches you.